Medurstand Understanding Medicine.
I'm Professor Azizur Rahman, and this is the second of the series of lectures on management of type 2 diabetes. In the first part, we discussed the use of some of the agents, and we also discussed the role of lifestyle changes, basically the dietary modification and physical activity. And we also discussed some of the traditional agents in the management of type 2 diabetes. And in this lecture, we are going to discuss some of the newer ones. Now, this is the list of agents available in our country: metformin and sulfonylureas and TZDs. This we covered in the last lecture. And we have insulins, various types. We have human insulins and we have modified insulins. Some are short acting, some are long acting, some are very short acting. So I think they deserve a separate lecture. In this lecture, we are going to discuss these three agents: GLP-1 receptor agonist, DPP4 inhibitors, and SGLT2 inhibitors. Uh, in GLP-1 receptor agonists, we have three agents. One is liraglutide, which is typically injected once a day, and dulaglutide, which is very conveniently injected once a week. We have just one strength available in our country, that is 1.5 milligram. And then we have semaglutide, just recently made available, and this one is from 0.25 to 1 milligram once a week. So these are very useful agents, and we will discuss them in more detail. DPP4 inhibitors, both vildagliptin and sitagliptin, are available, I think, for the last maybe 10 years, maybe minimum. We are very comfortable using them, and they are very useful drugs again. And the last addition to our armamentarium against type 2 diabetes is this SGLT2 inhibitors. And there are several members, but in Pakistan we have only dapagliflozin and empagliflozin. The dosage is different, and they have almost equivalent role in the management of type 2 diabetes, and their other additional roles are almost equivalent. Uh, what are GLP-1 receptor agonists, and what is the mechanism of action? First, we have to understand what are incretins. Now, incretins are two hormones. One is GLP-1, glucagon-like peptide 1, and the other is GIP, which is gastric inhibitory peptide. This one was not actually developed into drugs, but GLP-1 had great potential, and that was developed into some therapies. When we eat, the food is still in the stomach. It hasn't yet gone to the intestine. It is not even absorbed yet. But through some nerves or humoral signals, the intestine, the small intestine, specialized cells, K cells and L cells, they secrete these peptides. They are absorbed, and once absorbed into the circulation, they stimulate our beta cells to release insulin. Of course, this is the primary job of glucose, but incretins helps glucose to stimulate beta cell to produce more insulin. And they also inhibit alpha cell, because in the fed state we do not need glucagon. Glucagon is needed only in the fasting state, when we need glucose coming from the liver. In the fed state, glucose comes from the intestine, so glucagon needs to be inhibited. So incretins stimulate insulin and inhibit glucagon, both in a glucose dependent way, and they ultimately help to lower glucose. Now, once glucose is lowered, this mechanism is switched off. So this is very, very intelligent action. But these incretins even if we isolate them, even if we develop them, will not be clinically useful because they have very, very short half-life. There is an enzyme in the body called DPP4. DPP4 enzyme inhibits many proteins, but one of the proteins it inhibits is GLP-1. So our GLP, which is released from the intestinal cells, has a half-life of maybe 1.5 or 2 minutes. It is destroyed. It performs its function and it is destroyed. But in the body, there is no problem because once that is destroyed, more is released. So as long as incretins are needed, throughout the prandial phase, 2 to 3 hours after the meal, incretins are continuously released from L cells and K cells. But they cannot be used therapeutically because once injected, they will be destroyed within a minute or two by DPP4. So there are two possible solutions. One solution is to develop incretins which are not vulnerable to the effect of DPP4 inhibitors. So pharmaceutical industry has developed these GLP receptor agonists. These are the drugs which have effect very similar to our native GLP, but they are not destroyed by DPP4 and they have long half-life. They need to be injected subcutaneously, but since they're not destroyed by DPP4 and they work for like 24 hours, some work for 7 days. Now, main characteristics of this class of drug: potent A1C lowering effect. We classify glucose lowering drugs into two groups: those which are potent, those which have modest potency. And GLP receptor agonists, they are quite potent. They can lower HbA1c by more than 2%. And they do not cause hypoglycemia because their effect is glucose dependent. Once glucose is normalized, they do not secrete insulin more. And they are very, very friendly on weight. In fact, since they reduce our food intake by improving satiety and by delaying our gastric emptying, they actually help to reduce some weight. So patient on GLP-1 receptor agonist, especially if he's careful about his food intake, should be able to lose some weight. And they have cardiovascular safety data, very robust data. Not only they are safe from cardiovascular point of view, they actually extend some additional benefit. Some of the benefits of diabetes medicines are through controlling glucose. Of course, that is the main action. But these GLP receptor agonists, they extend some benefits over and above the effect through glucose control. And they have also proven renal safety. Now, even if somebody's eGFR has dropped down to 15, GLP receptor agonists can be used. So below 15 is contraindication, but anybody with eGFR 15 or above can take GLP receptor agonist. The downside, one, these are injections. Most people, they do not want to take injection. Although once a week injection with a very, very fine needle, you can hardly feel it, but still people, they do not want injections. I think the biggest issue with GLP receptor agonists is that they're quite expensive. In Pakistan, most GLP receptor agonists, the average monthly cost is approximately 18,000, which is, I think, quite a bit for most of our people. But of course, there are people who can very comfortably afford this price also. Then GI side effects, all these drugs, this is a class effect. They actually cause some nausea and some vomiting, some dyspepsia, at least initially. So I think patients should be counseled about these side effects. They tend to disappear after usage of these drugs for some time. And the initial phase, we can use some additional therapy some domperidone, some antacid to mitigate the side effects. Now, one reported side effect of GLP receptor agonist is pancreatitis. And we must note that pancreatitis is common in diabetic patient, commoner in diabetic patient as compared to non-diabetic population. But if somebody is using GLP receptor agonist, the chances of pancreatitis are slightly increased. So one has to be watchful. I don't really think that I would ever deprive anybody from GLP receptor agonists just because of fear of pancreatitis. But those who have suffered from pancreatitis once, they should not be given GLP receptor agonists. Then medullary thyroid cancer. This is actually medullary thyroid cancer, which is actually a rare cancer. GLP receptor agonists can increase the incidence of this rare cancer. So I think, except that we need to be a little watchful, this should not be a problem also. Now, since 2008, the FDA has mandated that every new drug must prove that it is effective in lowering glucose. It should lower HbA1c by a minimum of 0.5%, but it must also demonstrate cardiovascular safety. Now, this story developed after it was noticed that rosiglitazone actually increased cardiovascular mortality. At least that was the initial observation, although later on when audit was done and that was probably not proven, and the medicine is now still available for limited use, but that actually alerted all physicians and cardiologists about this possible increase in cardiovascular mortality. So I think these days every new agent has to have a cardiovascular outcome trial to demonstrate that the drug is safe from cardiovascular point of view. It does not increase cardiovascular events. So we have studies. LEADER is about liraglutide, REWIND is about dulaglutide, and SUSTAIN is about semaglutide. And these are the three agents which are available in our country. So I have bolded them. And EXCEL is about exenatide, and ELIXA is about lixisenatide. Almost all GLP receptor agonists, they have demonstrated their safety. And that's, I think, minimum. They have been demonstrated to be safe from cardiovascular point of view. And some of the agents like liraglutide in LEADER trial and REWIND and SUSTAIN, they actually have shown that there is some additional benefit. When benefit through glycemic control is there, but on the top of that, there is some direct beneficial effect on cardiovascular health. So I think if you consider that, these agents, GLP-1 receptor agonists, they have passed the test of CVOT trial. In fact, I would give it double yes, because not only they are safe, they have some additional benefits. And this is very relevant because in type 2 diabetes, 75 to 80% mortality and morbidity is related to cardiovascular health. So if there is any drug, even if it improves microvascular complication, even if it controls glucose, if it has got even slightest negative effect on cardiovascular health, that would not be very welcome. So I think these agents are very useful. Now, as I said, our natural GLP is very short acting, and one solution I offered was this development of GLPs which are resistant to DPP4 action. But another approach is to develop some DPP4 inhibitors. The scientists have been very successful in developing some agents which, if taken orally, they will destroy DPP4. So once DPP4 is destroyed, our own endogenous GLP will have longer action. But this would be like physiological action, because DPP4 inhibitors can only prevent the destruction of our own incretins, and you all know that in type 2 diabetes, our incretin levels are actually reduced. So that is why when we compare the effect of DPP4 inhibitor with GLP receptor agonist, the effect of DPP4 is quite modest. This was development of GLP-1 receptor agonist, and here the effect is much more because we use these drugs in pharmacological dose, and the actual plasma level of GLP-1 receptor agonist may be 10 times more of our endogenous GLP. That is why they have more glucose lowering effect, and they also have effect on weight, whereas DPP4 inhibitors are weight neutral. Now, some main characteristics of DPP4 inhibitors. First, I would like to highlight the upside. They are very well tolerated. In my experience, DPP4 inhibitors are like placebo and there are hardly any side effects. And they can be given once or twice, very convenient. 100 milligram of either agent, vildagliptin or sitagliptin, 100 milligram will destroy our DPP4 almost 100%. So there is no point in giving dose higher than 100 milligram, and we do not also give the lower dose. So I think mostly we give flat dose of 100 milligram. And DPP4 inhibitors pair perfectly with metformin. In fact, this pair is great because metformin primarily addresses fasting sugar, and DPP4 being indirect secretagogues, they address postprandial sugar. So a combination of DPP4 inhibitors and metformin will address both fasting as well as postprandial sugar, and both have almost same half-life, and they can be very conveniently combined into one pill and given twice a day. So I think that makes a very, very useful combo. No hypoglycemia, no weight gain with either agent, and so I think that is again a good benefit. CV safe, multiple trials have shown that they are cardiovascular safe. I will show you in the next slide. And the limitation of these drugs is that they have modest action. They can bring down your A1C by around 1%. They lose their effect as beta cells fail with time. Now, any drug which work through beta cells, sulfonylureas or DPP4 inhibitors, or even GLP receptor agonists, any drug which need intact beta cell, they tend to lose their efficacy with time, because we know that in all type 2 diabetic patients with time there is progressive beta cell loss, and there is a time when beta cells are not there, so all these drugs they become ineffective. So that will be applicable to DPP4 inhibitors also. There is slight question over the possibility of pancreatitis developing with DPP4 inhibitors, but I think this is unproven. I simply believe that from this point of view, DPP4 inhibitors are safe. The main characteristics of DPP4 inhibitors, I think I've covered it. No, I haven't. Now, talking about their safety, DPP4 inhibitors, they are quite safe. They have also gone through CWAT trials, and we have TCOS trial which was about sitagliptin, and we have VIVID trial that is about vildagliptin. Both of these trials have shown that sitagliptin and vildagliptin, they are cardiovascular safe. I'm not going to talk about these in detail because they are not available in our country. And CWAT trials have shown that these agents, DPP4 inhibitors, are cardiovascular safe, so they also get a yes here. Now we talk about this relatively new drugs, very important concept. You know, we need to understand a little bit of physiology here. SGLT2 inhibitors. This is actually sodium glucose, S for sodium and GL for glucose. sodium glucose co-transporter 2 inhibitors. We have SGLT2 and we have SGLT1. SGLT1 is primarily in the intestine where glucose is absorbed from the food, and SGLT2 is predominantly situated in the renal tubules. Now, a large amount of glucose is excreted into the glomeruli, almost 180 grams a day. And all this glucose passes down the tubules but is reabsorbed by the SGLT2 because we need this glucose. Glucose is our nutrition and glucose is very much needed for normal physiological function. So it is completely reabsorbed because we need it, and ultimately we pass very little or no glucose in the urine. So that is nature's great idea to prevent waste of glucose. But here we want it to be wasted because if we allow this glucose to pass through the tubule and then pass into the urine, that will lower our glucose level. So using that concept, scientists developed SGLT2 inhibitors. So once SGLT2 is inhibited here, glucose will not be reabsorbed, and depending upon what dosage you use, you could actually prevent almost complete reabsorption of glucose, and then almost all the glucose will be excreted in the renal tubules. And we know that in diabetes, this reabsorptive mechanism is actually stimulated because tubules are exposed to extremely large amount of glucose in diabetic patient. So by blocking SGLT2, by giving SGLT2 inhibitors, we allow glucose to pass to the urine. So that will have multiple effects. Number one, it will result in glycosuria. So patient needs to be explained that if he or she notices glucose in the urine by glucose testing, patient should not worry about it. That is actually the function of SGLT2 inhibitors. Number two, if glucose is lost into the urine and it is not reabsorbed, it will of course lower our plasma glucose, which is the aim. And third, since glucose is nutrition, by losing glucose in the urine, we lose some calories, so that will help to lose some weight also. So these are the three main advantages. Plus, since it causes some degree of diuresis, glucose of course will take some water with it. It will also lower some blood pressure. So I think some of the benefits of SGLT2 inhibitors are by lowering blood pressure. Now, this was the mechanism of action. Let's now talk about their upper side and the lower side, the downside. The main characteristics, potent A1C lowering effect. That means with the proper dosage, we can expect up to 2 or more percent HbA1c lowering. Convenient OD doses. Most SGLT2 inhibitors are long-acting and they can be given just once a day. They do not cause hypoglycemia and there is actually modest weight loss. Just like GLP receptor agonists, they can help you to lose some weight because glucose is lost in the urine. Although I understand once glucose is lost in the urine, it would perhaps stimulate one's appetite, and unless patient controls his food intake, it might result in increased food intake. So some of the weight lowering effect may be neutralized by this factor. And it pairs, the SGLT2 inhibitors pairs perfectly well with metformin, and they are favorable from cardiovascular point of view. In heart failure, in fact, they are beneficial. In heart failure, by lowering blood pressure, by lowering afterload, they actually prevent hospitalization and death from heart failure. In fact, SGLT2 inhibitors are used in heart failure without diabetes also. So they are that useful. The downside of SGLT2 inhibitors is that they can cause polyuria. And you know, in our country, this is an important factor because we do not have a reliable public toilet service. So I think polyuria may be a problem. And if you have polyuria and you do not drink water, it could result in dehydration. Now, this is particularly important in elderly and frail people and those patients who are already on diuretic for other reason, for hypertension or for heart failure. Theoretically, they can cause what we call euglycemic diabetic ketoacidosis. There is a complex mechanism, and I will not go into the detail. But I think if patient is explained properly to drink water, this side effect can be avoided. But of course, an occasional patient will develop DKA, and I think we need to then stop this medication. If then again through dehydration, there is a possibility of renal shutdown. And then the SGLT2 inhibitors, although they protect our nephrons, but currently a GFR of less than 30 is a contraindication. This is something which is difficult to understand. These days, if somebody has microalbuminuria or macroalbuminuria, GFR is less than 90 but more than 30, we feel it is a very, very compelling indication for the use of SGLT2 because they can prevent further progression of renal damage. So this is actually very useful drugs in heart failure and CKD. And as I will show you the guidelines, in those who have heart failure or CKD, these agents, they are preferred. So coming to CWATCH trials, SGLT2 also have gone through these trials. EMPA-REG was about empagliflozin and Declared-TIMI 58 was about dapagliflozin. Canvas was about canagliflozin, but that is not available in our country. So I have focused these two, and both these agents, they have passed this CWATCH trial, and I give double yes because they're not only cardiovascular safe, they actually extend additional benefit, especially in renal protection and especially in heart failure. So in these two categories, SGLT2 inhibitors are very useful. Now, we are coming to the consensus statement. This is a very, very robust document, Management of Hyperglycemia and Type 2 Diabetes, a consensus report by American Diabetes Association and the European Association for Study of Diabetes. Now, these are two main societies for the diabetes. So they have issued a consensus statement. So whatever is mentioned here, I think you can practice that with confidence. You can quote that with confidence because it is backed by two very, very large authorities. This was published in two journals, both one owned by ADA and the other one owned by EASD simultaneously, and these are available free online. Diabetes Care is Journal of American Diabetes Association, and Diabetologia is journal by European Association of Study of Diabetes. The same document was published in 2018 simultaneously. And in fact, there was some minor updates in 2019, and you can read those updates also, but this document is worth reading. Now, there's some limitations of the guidelines. I think we all follow guidelines. They're very useful, but there are some limitations. One, they apply to communities and not to individuals. And when we as physicians, we treat patients, we actually treat individuals. So guidelines, they do not necessarily apply on individuals. So I think that is one problem. You have to individualize treatment. And the second point is that they assume that you are starting the management from the beginning, from the diagnosis. Of course, that may be true, but sometimes patient comes to you when he is already under treatment for the last maybe 10 years. So you may not start from the beginning. And don't address multiple comorbidities. A real world patient may have multiple comorbidities. Patient with diabetes may have CKD, may have asthma, may have stroke, may have hyperuricemia. So I think all those issues needs to be addressed when we make individual plans. So guidelines are very useful, but when it comes to an individual patient, we must individualize the treatment plan in view of that patient's unique situation. Now, these are the principles of these guidelines, decision-making cycle, and this is again from the same document, and patient-centered approach. Patient is in the center of this picture, and two primary concerns are prevention of complications and to improve patient's quality of life. So patient in the center, and these two very important considerations, prevention of complications and maintaining or improving quality of life of the patient, we have to make several considerations. Address key patient characteristics, specific factors concerning that particular patient who is sitting in front of you, and shared decision making. This is very much highlighted these days. We can't simply make a decision and impose it on the patient. So we have to make a shared decision. Patient has to be empowered with knowledge, and then of course physician will take the leading role to explain to the patient that why a particular agent is recommended, and patient will make the final decision and agree on a management plan, whether we decide in favor of a tablet or two tablets or an insulin. So I think we need to agree on that, and then we implement that plan, and then we have to do ongoing monitoring, and we have to offer ongoing support to the patient, because patient would need your help all the time. And then periodically, typically every 3 months, we need to review that plan, and every time we listen to the patient and we examine the patient and we go through patient's lab, particularly HbA1c, and see if the plan is working. If the plan is working, fine, same may be continued. Otherwise, we take next step, and next step could be increasing the dosage or adding a new agent or making an altogether different treatment plan, like going for injectable or insulin, something like that. So I think this is actually a summary guidelines 2018. This picture shows that we start with the lifestyle changes in every patient. It is like mandatory that every patient must follow a specific lifestyle pattern if he or she is diagnosed with diabetes, regarding diet, regarding weight, regarding exercise, regarding smoking, regarding comorbidities, regarding glucose testing and follow. So all these things needs to be done, and typically we start metformin also at the time of diagnosis. In my earlier lecture, I mentioned that those patients who have modestly high HbA1c, like 7 or less, and you can see that they are highly motivated to try lifestyle changes alone, there is no harm. You can evaluate the patient after 3 months and then see if patient needs metformin. But most patients would need lifestyle changes and metformin. Typically, patients have HbA1c of 10, 11, 12 at the time of presentation. So we feel that just trying lifestyle would be perhaps waste of time. So might as well add metformin. Now these two are the starting treatment, and they go on till the end, both of them. Other agents will be added, some will be then removed, then injectable will be added, but these two things, lifestyle changes and metformin, will be applicable till end. Metformin will be needed to reduce when GFR is below 45%, and perhaps we will need to stop when it is below 30, but lifestyle changes of course will continue. Now after metformin, there are several agents which can be used. What we do is we re-evaluate them and categorize them into 3 groups. First of all, the majority. The guidelines actually they start from this side, but I start from this side because I think it is only fair to address the majority first. Majority are those who have diabetes, but they do not have heart failure, they do not have kidney disease, and they are not particularly at a high risk of atherosclerotic cardiovascular disease. At least they do not have atherosclerotic cardiovascular disease at the time of diagnosis. So this will constitute majority, about 80%, and remaining 20%, they will fall into these two groups. Either they would have heart failure, or they are at the risk of developing heart failure, or they have CKD, or they are at the risk of developing CKD. So if you have these patients, I think they are to be treated slightly differently. And if somebody has atherosclerotic cardiovascular disease, they have existing coronary artery disease like angina, they have suffered from TIA, they have suffered from stroke, they have undergone angioplasty or peripheral vascular surgery, so they would qualify to be in this group. And the 2018 guidelines say that you don't have to have these actually complications even if you are at a increased risk. For example, somebody who's diabetic and has a strong family history of ischemic heart disease and is a smoker, so I think he will also fall in this group. So approach is slightly different. Now let me give you some details how the further approach is. Now if in majority, actually the guidelines, they subdivide this group into three. Number one, group where there is a compelling need to prevent hypoglycemia. The second is there is a compelling need to prevent weight gain. In my understanding, every diabetic patient, there is a compelling need to prevent hypoglycemia and to prevent weight gain. And third subgroup is where cost is major issue. So I think our population will be in this group. And I think if the cost is really the big issue, then sulfonylureas and TZDs are perhaps, they offer best value for money. Cheap but effective. Of course, we're talking about a second line drug. Metformin is already there. So we can combine metformin with sulfonylureas and TZD if cost is a major factor. If cost is not a major factor, and DPP4 inhibitors and SGLT2 inhibitors are also, I think, only moderately expensive, these should be preferred over these two because they are weight neutral and they do not cause hypoglycemia. So in this group, after metformin, I think ideally DPP4 inhibitors and or SGLT2, but if cost is really an issue, then sulfonylurea or TZDs. So after this, we go to this group, and I think in these two groups, GLP-1 receptor agonists and SGLT2 inhibitors are recommended. In atherosclerotic cardiovascular group, GLP-1 receptor agonists are preferred agent if they are contraindicated or patient cannot afford. As alternative, you can consider SGLT2 inhibitors. In heart failure and CKD, I think SGLT2 inhibitors are preferred agent, but if there is a contraindication or patient cannot tolerate, then you can consider GLP-1 receptor agonist. Of course, both can be combined also one by one because both, in addition to metformin, will make a great combination because metformin helps to lose weight, GLP receptor agonist helps to reduce weight, and SGLT2 inhibitors help to reduce weight, and all do not cause hypoglycemia. So this will be a real potent triple combination without the risk of hypoglycemia. So since most of these agents, they depend on intact beta cells, GLP receptor agonists, they depend on beta cell, SGLT2 inhibitors are independent, sulfonylureas, they depend on beta cells, DPP4 inhibitor depends on beta cells, and TZD also, I think, indirectly they depend on beta cells. So and we know that with time beta cells fail in type 2 diabetes, so we will definitely need something as replacement of insulin, and that of course is insulin. Now I'm not going to go into the details because I have a separate lecture on insulin, but typically as per guidelines, initially we start with basal insulin. Basal insulin is the one which works for 24 hours. And when we start basal insulin, oral agents are continued. Maybe we can take sulfonylurea off, but other I think agents are typically continued. Then a time would come when basal insulin would not be sufficient. We will need to add a prandial insulin to give full coverage. Now some more slides combining oral agents with injectable. We have discussed the oral agents. The injectables are insulins and GLP-1 receptor agonists. Now, I have used these examples of traffic lights. I think ADA and ESD has also used the same signs. I have reproduced them in my own way. So, metformin can be combined with insulin and GLP receptor agonist without any problem. So, there's a green light here. Similarly, SGLT2 inhibitors also do not have any compatibility issue with injectables, so they again green light. So if patient is on metformin and SGLT2 inhibitor, you want to add injectable, go ahead, patient can continue taking these two drugs. Combining oral agent with injectable, now TZD, and there is a orange light blinking. That means conditions apply. You have to now make your own judgment. Like in traffic lights, if the orange light is blinking, you have to stop for a while and see if it is safe to enter the crossroads. So I think that means once somebody is on TZDs and you start insulin, there is a risk of weight gain. So I think best is to stop TZDs. But since TZDs are insulin sensitizers, so it makes sense also that if you continue TZDs, the lower dose of insulin will do the job. So either way you can decide, but as far as I know, TZDs are not recommended with insulin. They are used off-label, but they are not typically recommended. So you make your own judgment for that patient. They can be continued or they can be stopped. Now, sulfonylureas, again, you can make a point. If you're giving insulin, then insulin secretagogues may not be needed. They were not working anyway because beta cells are destroyed. So we could actually stop sulfonylureas. But if there is still some beta cell reserve, and one can make a point in continuing sulfonylureas also. So you make your own judgment. I tend to stop sulfonylurea when I start insulin. And the third one, DPP4 inhibitors. Now DPP4 inhibitors, they prevent destruction of our own GLP. And once we use GLP in a large quantity, then DPP4 inhibitors are perhaps not needed because DPP4 have very modest action as compared to GLP receptor agonists. So I think DPP4 should be discontinued because they will only add cost to the treatment plan. So now we are, I think, coming to the end of the presentation. This is perhaps the second last slide. Our glycemic control. Now, if patient presents with A1C of say 13, that I've seen many times, patient presenting with A1C around 13, and normal is A1C of less than 5.7. So an ideal treatment would be the one which can bring HbA1c down to normal, that is less than 5.7. But it becomes literally harder and harder to bring it down to 7 or less. And once we approach normoglycemia, there is risk of hypoglycemia. Although I have mentioned many drugs which do not cause hypoglycemia, but with those drugs, it is usually not possible to bring the HbA1c to the normal level. So inevitably there would be hypoglycemia. Hypoglycemia is a major issue. So to avoid hypoglycemia, ADA and EASD, they have given us the goal of 7. So we feel that with the use of these drugs and following the algorithm I have given you, it may be possible to bring HbA1c to 7 safely without, or at least with, acceptable risk of hypoglycemia. And in individual patients, if patient is relatively young, if patient has not developed any comorbidities, and he is less prone to the bad effects of hypoglycemia, we must try to bring it down to 6.5 or 6 or maybe even less. But beware of hypoglycemias when you try to achieve this ideal goal. Summary of glycemic control. Diabetes is very complex. Hyperglycemia is one of the main components, and 3 lectures will be focused on the management of hyperglycemia. And I have a separate lecture which will focus on additional therapies which reduce diabetes related complications. But this is the summary of glycemic control. Metformin remains a first line treatment of all type 2 diabetes patients, and it is continued till the end or when GFR is less than 30. In every international meeting, there is a debate whether metformin should continue to be the first line or some other agent like DPP4, SGLT2 inhibitors, GLP receptor agonists. They're all contenders to be the first line. There is a debate, but I remember every time it is decided that metformin should continue to be the first line because it is incredibly cheap, incredibly safe, and incredibly effective. Although in some specific situations, an alternate agent may be used as first therapy. Cardiologists, they have already started using SGLT2 inhibitors as first line treatment. So I think, but by and large, metformin remains the first line, and the second line, any of the available second line option, those without weight gain and without the possibility of, without the risk of hypoglycemia, are preferred. This I refer to, there are many agents I think I discussed in the lecture. So early CV evaluation, that means you need to evaluate from cardiovascular point of view. You don't wait for any atherosclerotic or cardiovascular disease to develop. You evaluate them early, and if there is increased risk of ASCVD or if patients have ASCVD, then after metformin, GLP-1 receptor agonists are preferred. Now, then you again assess their kidney function. You estimate their eGFR from the creatinine. You have their microalbuminuria also. And if there is some nephropathy, then SGLT2 inhibitors are preferred. Now, then you assess from the cardiac point of view again if they have heart failure, maybe due to some other reason. If they have heart failure, then SGLT2 inhibitors are preferred. Now, of course, you would know about heart failure by doing an echo, and if ejection fraction is reduced, these patients, they would benefit from SGLT2 inhibitors. Remember, these agents have specific benefits, but most of the benefits are driven through better glycemic control. So our main focus should remain glycemic control, because there are some cheap drugs which can do this job very well. So we should never forget that in diabetes, we are primarily treating hyperglycemia, although I will highlight in my next lecture, there are things other than hyperglycemia which are important. They must need to be considered, but hyperglycemia, the glycemic management, should never lose focus. With that, I'd like to thank you for watching this video, and just to remind you that this was the second in the series of 4 lectures, and we will continue with the management of diabetes, and in the next lecture we will focus on insulin. And of course, when we start insulin, we mostly continue oral agents also, but oral agents we've already discussed in some detail, and in the next lecture we will discuss various insulins, the formulation and the proper dosage. And till then, I thank you very much. Take care of yourself. And this was Professor Azizur Rahman from Medurstand, Understanding Medicine.